Great. So thank you, Sarah, for your time today. I appreciate you're a very busy person at the moment, so we really appreciate having your time today to run through the question and answer session. So we appreciate menopause is such an important topic, is really key to a lot of our employees really, and we've been a bit overwhelmed actually with the conversation that started already and the responses we've had from all across the business with questions, experiences and sharing experiences, which has been fantastic. So the purpose of today really is just to carry on with that, raise further awareness and try and help all of us really, our employees, to help us in our own lives and in the workplace, just to understand more, recognise symptoms and how to deal with it and where to go when we've got concerns and signposting information really. So I thought it would be helpful if to begin with you could just give us a little bit of background, particularly of Newson Health and maybe your experience as well to date. Great.
Yeah, of course. Yeah, and thank you for inviting me. I think it's brilliant that Shoes Owner, embracing the menopause, because it's so good for the women. And it's actually so sensible and clever as a business as well, because you want to keep all your good staff, don't you?
Yes.
So I'm Dr. Sarah Ball. I'm a GP. I've been a GP for 20 years, and then 3 or 4 years ago I met Dr. Louise Newson and went to work in her clinics. That's Newson Health. So we're based in Stratford-upon-Avon, but we have once the pandemic arrived and we realized actually that online consultations are actually highly effective for menopause. We've grown hugely over the course of the pandemic, so we have doctors all over the country now doing remote consultations, but we can still see patients face to face in Stratford, and we sort of do holistic menopause care. So yes, there's the medical bit of it, but we've got yoga teachers and we've got scanning machines and we've got nutritionists and pelvic floor physiotherapists, for example. So we can sort of try and do the whole shebang, if you see what I mean.
Yeah, great.
And then we've also, it's all very nice to be able to have we've got a lovely building and it's all very nice and plush, but of course not everyone can afford to go privately, and we all wanted to work in the NHS doing menopause work, but actually the NHS just isn't yet set up to provide adequate menopause care for everyone that needs it. So we do a lot of other stuff as well. So hence why Louise formed the menopause charity, and we do free education for all healthcare professionals across the world. And we've got the app as well, which we can talk about later. So we're very much there to try and help everybody, regardless of ability to pay for care.
That's fantastic. That's brilliant. I think then we've had such a mixture of questions really that we've had. I think a really good place to start is, what is the menopause, I guess? At the very beginning.
It's a good question, because actually I think it confuses lots of people, and some people just don't ever think about it. I think you just presume. I think a lot of people think, I don't need to worry about that till I'm 50. And that's just something that happens to old people, and it'll be a few years of maybe feeling a bit hot and then it's gone. But actually it's completely different to that. So menopause technically means that it's one day in our life. The menopause, actually, it's the day when you've gone a whole 365 days without a period. So it's actually that really short space of time. But the average age that we go through that is about 51, but of course for anything to be average, you're going to have a lot of people that fall a long way out of that range. So it's actually possible to have an early menopause, and we call it early if it happens before the age of 45, and then it's also possible to have an even earlier menopause, which we call premature ovarian insufficiency, and that's when your ovaries have kind of run out for all sorts of different reasons, but it's that's sort of quite an abnormal scenario. But actually it happens to about 1 in 100 women now, and even it can even happen earlier. So we have some patients at our clinic who are in their 30s or 20s. We've actually got a few teenagers, so it's rare, but for most of us it is the early 50s where the periods stop. For most of us, it's a gradual transition where the ovaries just gradually run out of their eggs. But actually, for some people, it can be a very abrupt process. So if you have your ovaries removed, for example, then you're going to go straight away into the menopause. Or if you have certain treatments that switch ovaries off, like chemotherapy, for example, that is going to plunge you straight into a menopause. So there's lots of different experience of menopause. And I think probably where the most confusion comes in is what we call the perimenopause. So it's the lead up to the last period, which actually can be quite a car crash for lots of people, because we often have symptoms, but we're still having periods, or we're still using contraception that is hiding our periods. So we don't even think of menopause as being an issue. But so the average perimenopause lasts about 4 to 12 years. So if you go through your menopause at the average age of 51, actually you could be getting symptoms from your late 30s onwards. And that's why, you know, if you think of all the women in their 40s, well, all over the place, but especially in the workplace, that's an awful lot of women that are struggling, and they often don't know why they're struggling. So that's why spreading awareness is so important.
Yeah, and I think that was the biggest surprise actually over the last year, is finding out about perimenopause. Because I think previous generations, I'd never heard of it until probably 12 months ago. And it's, as you say, it's such a huge period of time really in your life.
And actually, if you look at graphs of our hormones, so basically when we're in our, say, 20s and 30s, for most of us, our hormones are gently going up and down. We get estrogen, which is like party hormone, and makes us want to have a period. And then the progesterone comes along in the second half of the cycle, and that's our calming hormone, which also then deals with, actually forms the period each month. So it goes along kind of like that. And then when we get to our perimenopause, it goes really high and then it falls off down. So we're literally on a roller coaster. And so that party hormone goes a bit crazy, which actually, you know, all parties are good, but if they go on too long or too hard, you know, it's a bit dangerous. And then the progesterone, this nice calming hormone, drops away, so we don't have calmness anymore, which is why so many women get anxious, because that's kind of gone, and they stop sleeping so well and things like that. So it's a really quite scary for many women.
And I guess it comes from nowhere. It'll just happen 1 month.
And it's kind of quite on and off to start with. So you might have a month where actually your hormones are behaving, so you feel okay. And then actually the next month, the ovary doesn't work very well, so you feel awful. And then you think, oh, it must be my busy job, or, you know, I've got, you know, too many children to run around after, or I'm looking after my elderly parents. And then you then kind of think, oh no, maybe I'm not right, maybe I'll do something about it. And then you feel fine again the next month. So you end up in a like, what do I do? But you notice it's like a gradual, it like subtle, creeps in. But because women, we're very good at putting up with stuff, we're very good at, you know, looking after everyone else and not putting ourselves first. Actually, often women don't realize until they're kind of about to crash, if you see what I mean, that actually things have got so bad. How did this happen? And they look back and go, actually, I was suffering for years, but I didn't see it coming.
No, it's true. And I think it's the experience of so many women that certainly that have emailed us and chatted with Claire as well. No, it's so nice to understand why it could be happening, isn't it?
Yeah, exactly.
It's a weight off your mind, really.
We need reassurance that we're not going mad, that we're not link, that actually, you know, this is expected. You know, if you know, hormones going up and down like that, we can't possibly be completely fine. And there's lots of other women going through it as well, isn't it? Not just you. Everyone goes through it. It's just everyone has a different journey, and that's what's so interesting, that you can't just, you know, oh, my neighbour flew through it, or, you know, my other neighbour, it was awful. It doesn't actually mean that's going to happen to you, but if you have an idea of what might happen, at least, you know, forewarned is forearmed.
No, absolutely. Yeah, definitely. Great.
Yeah. And I think the one thing that I've certainly noticed, and going around seeing staff as well, is they didn't realise how many symptoms there are. That's been an absolute massive eye opener.
A few of them behind us.
It's wonderful. It's a wonderful poster. It's really helpful. And the way I look at it, I try and simplify everything. So I have quite a simple brain, actually. And basically, there's the physical symptoms, which is, some people have heard of them. So that is the hot sweats and flushes, which basically, somebody asked a question about why they happen, and it's basically the it's to do with the brain, and the lack of estrogen in the brain means our thermostat stops working properly, essentially. So you get these horrible flushes and night sweats, which then stop you sleeping, and they're embarrassing. And things like migraines, everything dries out. So our skin starts to dry out, we can get dry eyes, and then we can get itchy because of that. You may still be having your periods. So in the perimenopause, you're still having periods, and they actually may be much heavier to start with. So that in itself is very draining and debilitating. And then they do tend to lighten, but not always. Joint aches and pains are a really common symptom of the menopause that hardly anybody realizes is that. They just think, you know, that they're getting old, or, you know, that they need to do more exercise, whatever, and actually their joints really hurt. And so, and women just feel really, really fatigued. Even the women that are managing to sleep okay still feel really fatigued in menopause and perimenopause. So there's the physical symptoms, and then there's the psychological symptoms. And I would say, you know, given as I see menopausal women all day, every day, I know it's the psychological symptoms which are the biggest issue. Because anxiety, because that's usually the first thing to creep in. And once you're anxious about stuff, you then worry even more about all the other symptoms. So it kind of makes it even worse. You get quite low in mood, but it's slightly different to what we call clinical depression. It's more that sort of flatness of mood, and the ability to see that your life is actually, on the face of it, probably quite nice and everything's okay, but you're just not enjoying it like you used to.
Would you say it's more of a detachment then, that you feel a bit detached from
a bit detached,
the norm kind of thing? And
a bit like life's gone into black and white, whereas it used to be in colour, that sort of thing. And then women feel guilty about that, and so that makes it kind of worse. And they can get quite paranoid. So a lot of, you know, oh no, my boss doesn't think I'm doing a good enough job, or whatever, or my friends don't like me anymore, or that sort of thing happens, and we sort of start to lose self-confidence and self-esteem, which then kind of makes the problem even worse. And kind of, and we get this brain fog as well, so we can't put a sentence together properly. And we, you know, go into a room and can't remember what we went there for, or we can't concentrate. So that can affect us at home and at work. So it just sort of all kind of gangs up on us. And you know, and I'm not saying that everyone is like this, but at the worst end of the spectrum, it can lead women to have quite, you know, dark thoughts and wondering about whether they want to be here anymore. You know, it can get that bad, and so we need to kind of, you know, wake up and realize that women's mental health in midlife is almost, not entirely, but hugely dependent on our hormones, and we need to think, this woman's not herself, think menopause, you know, because it's
you just wouldn't naturally make that link, would you, between that and the hormone? You'd figure it completely separate until now, really.
And then there's the third group of symptoms, which is the ones that a lot of people struggle about, but I don't seem to, which is the genitourinary and sort of sexual type symptoms. So basically, when we lose estrogen in our bladder and our vagina and the vulval area, everything dries out down there. So we can often get vaginal dryness. So that can be quite painful. It can be painful to do normal day-to-day stuff like wear jeans or lycra, or go for a run, or ride a bike, or ride a horse, or whatever. But actually, it can make sex really uncomfortable, and it can give us things like being prone to urinary infections and cystitis and things, and also our libido drops as well. Even if things are comfortable down below, the libido drops because we also lose a third hormone called testosterone in our sort of 30s and 40s as well. So we don't have that sex drive, so that can really impact on relationships as well, just to make the whole, you know, kind of picture even more tricky to navigate. So there's an awful lot of symptoms, and there are some, you know, kind of slightly weird and wonderful ones as well. Weird tingling in your fingers and hands, your fingers and toes sometimes. Someone asked about night cramps, I remember. It can happen around menopause. It's not a common menopause symptoms. Night cramps is usually to do with not enough hydration, or not enough potassium in the diet. So sometimes a banana can help, but there's an awful lot of symptoms, and the clever thing really is to join the dots. So, you know, we can go to our GP because our joints ache, or we could go to our GP because we've just had a urine infection, or we could go to our GP because we're feeling a bit anxious and struggling with work, and go to our GP because we used to have migraines but they've got much worse. And actually somebody, it doesn't matter who it is, even if it's the woman herself or the doctor, needs to go, hang on a minute, all those things are actually to do with the same problem. They're not separate issues. But that's again another kind of big problem we have with putting it all together and working out what to do.
Yeah, great, fantastic. There's so many symptoms there that you've just gone through, and I think one of the main questions that we got from employees was, does it stop and when will they all stop?
Yes.
So I suppose, how long do the symptoms all go on for?
Does it go on for? It's a really good question, and none of us have that crystal ball, unfortunately, for us as individuals. So some of it, you know, if you watched Forrest Gump, you know, where he's sitting on the bench with that old lady and she says life is like a box of chocolates, you never go what you're going to get. I always think of having like a box of chocolates in front of me, like quality something, and you close your eyes and you put your hand in and you take a whole handful, and you could get any combination of symptoms, and that's your lot kind of thing. So for example, like most of us, about probably 3/4 will get hot sweats and flushes. The other quarter will never have one ever. Doesn't mean they're not in menopause or that they're struggling any more or less. It's just different. So most of the symptoms on average will last somewhere between about 5 and 7 years. That's quite a long time. But some of the symptoms will never go away. So if you've got any problems with the waterworks or the vagina or the vulva, basically that's not going to get better. So don't wait, because it's just going to get worse and worse. And someone asked about brain fog and whether that gets better. There's quite a lot of research looking at this at the moment, and it looks like for most people the brain fog probably does clear as you get a bit further into menopause, but that's not across the board. So you can carry on feeling a bit, you know, a bit strange unless you do something about it, which obviously we'll come on to.
Yes.
And there are certain things which make symptoms worse. So alcohol is probably the biggest problem. And what so many of us do, completely understandably, is we use alcohol as a psychological crutch when we feel a bit out of sorts. If we feel anxious or we can't sleep properly, or we just want to relax, we use alcohol, and that actually makes all our symptoms worse. So we then get in another kind of vicious circle. And smoking as well. Smoking is obviously really bad for our health for loads of reasons, but actually women, heavy smokers, are actually slightly more likely to have an earlier menopause as well. So it's another kind of thing to think about. And someone asked about night sweats as well, and saying what can I do about them, and obviously we'll go on to treatment, because actually treating it is a sensible thing to do. But actually even night sweats aren't good for us. So even if you feel you're coping with them, they're actually not a good marker for your future health either. So if you have lots of hot sweats and flushes, you're more likely to have other health issues later on in life, like heart disease and dementia and osteoporosis and things like that. So it is really sensible to think about treating them. And yes, you can wear loose fitting clothing and make sure that the room is kind of cool, and try and avoid alcohol, but that's not going to solve it. It may make it a bit better, but it's not going to solve it.
Oh, excuse me. I think some of the biggest hurdle that we would face is how to actually get diagnosed, or how to who to go to, and making sure that there's the support there from your GP as well. You've got a GP that would listen. Yes,
yeah, it's really difficult, and I guess is why we are so keen on pushing awareness, because it is, for me, it's not difficult. You know, I can spot a menopausal woman, a long way off, but we don't see it coming ourselves as women. You know, I didn't see my own perimenopause until, there was a car crash. And so we have to almost empower women to go, look, who is going to look after you any better than yourself? If we just give you this bit of information and you keep an eye on yourself, and when you think, I think something's not right here, something's linking all these problems, I think my hormones are changing, I think I might be going into this menopause transition, actually you can do most of the work yourself. I know it sounds like an odd thing to say from a doctor's point of view, but basically only you know your body better than anybody. So what we tend to suggest is first of all, when you start to think, I think maybe could this be menopause, get a list of all the symptoms. So on our website there is something called the Menopause Symptom Questionnaire, and if you actually just in the search box in the medical library just type questionnaire, it will come up. So it's got the main sort of 20 to 30 symptoms on there, and if literally it's just a tick box, and it starts to go, oh yeah, I have got that as well, I have got that as well. And so you can then, if you want to, that could just be a one-off thing that you do. Or some people might, for example, if they've got our Balance app, they might track their symptoms, every day or every week or every month, and you start to see patterns. You can actually print off reports from the app that you can then take to your doctor. So if you can then go to your doctor and say, I think I've got an issue with perimenopause, I've got these symptoms here, look at my form, my periods have either, I've noticed they're maybe changing, you're probably still having them when you first notice symptoms, but they might have got a bit heavier, they might have got a bit lighter, they might be a bit more closer together, they might be a bit more spread out, but you've noticed something has changed. And you can go to your doctor and say, I think this is what's happened, what do you think? So you've already done quite a lot of the work for them, because otherwise they will start with let's deal with your achy elbow and here have some paracetamol. You go, no, hang on, we're missing the point. So it is what we call a clinical diagnosis. So clinical just means you should be able to tell from talking to somebody, basically. But we have become very much a profession and a society that expects an instant test, an instant answer, black and white answers. And actually that's wrong for the menopause. But a lot of people say, can I have a blood test? You don't need a blood test to diagnose your menopause if you're over 45. It's actually encouraged not to have them, because if you think of that graph that I said where your hormones are going up and down, we might get you at the top, we might get you at the bottom, but it's not going to tell us what your ovaries are actually doing over more than that moment that you took the blood test. So that's why we don't encourage blood tests after 45, because they're just misleading. Under the age of 45, they may be helpful, but they're more helpful to exclude other things rather than to actually rule the menopause in, if you see what I mean. So you might go, let's just check the thyroid's working properly, especially maybe if you've got people with thyroid problems in your family, because that can give similar symptoms to the menopause. Or you might want to double check someone's not anemic, for example, or got a vitamin D deficiency, but it's not going to, that's really the only role of blood tests, to be fair, unless you're below 40, in which case blood tests become more important. So it's really about pattern recognition for the woman herself and her doctor. And if the woman's still having periods and they've changed, that helps to clinch it. But we hear a lot of women that say, oh, my doctor said it couldn't be menopause because I'm still having periods. And then my head's back in my hands and going, no, there's this whole thing called perimenopause where you're still, but actually if the woman knows that and she's empowered and polite, you can often actually end up teaching the doctor.
I would agree. After a recent, and I'm quite happy to talk about it because I think we should, but after a recent conversation I had with my GP, when I was just sort of questioning, and he was pretty much, you're a little bit young. Well, I'm not, I'm over 45. And he pretty much was like, but the minute I mentioned that I was on the menopause committee, he was like, oh, that's excellent. And the tone completely changed. And it was, which was quite funny. And he's like, oh, I think it's wonderful that you're doing that. And
I think that's the really key thing about, I've obviously been on both sides of the fence. I've been that GP and I've been that patient. But actually, if when we go to our doctor, the idea is that we try and explore what is the patient's ideas already and what worries them the most and what are they expecting to get out of this consultation. And if you just always keep those three ideas in your head and know from a patient's point of view, if you know that the doctor would like to know those things and you've already thought about it before you've gone into the room, actually you're on a much, much more positive pathway to getting actually what you want and need.
I think a lot of women feel that they're just going to end up getting fobbed off with, oh, you're fine, and just rest or whatever, and you'll be okay, and you've just got to kind of get through it.
Yes, and I think, unfortunately, there's some amazing GPs out there where you'd be safe as houses and they'll do everything wonderfully, but unfortunately there's just some GPs who GPs never get menopause training actually. I trained myself, most of us trained ourselves, which is bonkers, and it will change. That's a ridiculous state of affairs, but there's literally some GPs that just don't know anything about it, don't acknowledge it, or have no sympathy, or have just been fed a load of wrong ideas and myths about it. So if you've just got that bit of knowledge, you'll be in the driving seat, which is a far more powerful position.
Yeah, that's great.
Absolutely.
I know a lot of the emails that we had talk, there's so much going on in the body and with the hormones changing. There's a worry that if they've previously, say they've had diabetes in pregnancy and maybe attributed that to what risks there are that come with menopause, really.
Yeah, and that's a really important point, because the menopause, everyone kind of knows that there's symptoms of the menopause, but actually the menopause is also a long-term hormone deficiency, in the same way as having diabetes or having an underactive thyroid, for example, are long-term. You've run out of a hormone, and therefore conventional medicine says we'll replace that hormone. So with the menopause, you've run out of estrogen and progesterone and testosterone actually, but for the sake of for now, it's running out of estrogen, which is the most problematic thing, because estrogen is a bit like, it's an oversimplification, but it's a bit like having a preservative. It keeps our body in its healthy state. So once we lose it at the menopause, our bodies then start to deteriorate, unfortunately. So after the menopause, we're at much, much greater risk of getting heart disease, of getting blood clots, getting dementia, getting osteoporosis, getting things like mental health issues. Diabetes is one of them actually. So as our metabolism changes after the menopause, we are more prone to diabetes, and problems with like long-term issues with recurrent urine infections and things like that. So it's actually, this sounds a bit awful, but if we rewind to Victorian times, we ran out of our hormones when we got to menopause. It didn't matter that much because women didn't live that much longer afterwards, but now we live years and years afterwards. Actually, it's a real, it's not nice for us women. We've got a much higher rate of dementia, for example, and osteoporosis than men have, and that's because we've run out of estrogen. So it's a really unequal scenario kind of thing. So we need to, when we're thinking about our menopause, we actually need to be thinking not just about getting through what we're currently experiencing in symptoms, but actually how do we make the rest of our life healthier.
What sort of, I'm sure there's a vast list of things that we could all be doing to sort of help ourselves during the perimenopause, but sort of, are there some good tips out there that you've got that we could do? Or
I think by far the most important thing is to arm yourself with knowledge. So actually, if you're listening to this, then you're already, on the right track. So, if you know what's coming, that's a good way of tackling it. I think talking about it, which obviously your company clearly are, don't feel isolated, because that's going to make things worse. We need to think about our lifestyle, and that's because lifestyle is always important, but it's like the magnifying glass is on us at the perimenopause. This is like the critical timing, where if you make healthy changes now, you're going to reap massive benefits for the rest of your life. So, but I also want to counter that by saying you can't lifestyle your way out of the menopause. So you can't decide to become, do yoga 10 times a day and live on, spinach and nuts and, never touch a drop of alcohol or smoke again. And you can't. So I've heard many women who are maybe told by a healthcare professional, well, if you go away and lose weight or stop smoking, then I might have a chat with you about the menopause. That doesn't help, because actually, if you're very symptomatic with menopausal symptoms, you can't do those healthy things, because actually all you want to do is shove cake in your mouth and lie on the sofa and drink wine. So yes, if we can make changes to lifestyle, great, but it shouldn't be a stepwise approach, if you see what I mean. But the most important things about lifestyle are what we put into our body. So alcohol, as I've already said, is not good for us, and it's kind of, unfortunately, it gets much worse for us around the menopause. Alcohol actually competes in our body, in our liver. So our hormones the hormones we have got left, or any that we put into our body, aren't going to work so well if you've got alcohol around. So that's a big one, unfortunately. Eating healthily becomes even more important. We really want to support our gut health and our overall health by putting healthy foods into us. So we're sort of talking sort of Mediterranean style diet, really. So predominantly plant-based, but if you're going to have meat, trying to have lean meat, plenty of fish and shellfish, loads of sort of fruit, veg, legumes, whole grains, that sort of thing, lots of fibre, but trying to avoid all the sugar and the sort of refined carbohydrates and the processed sort of grains, and too much. There's very healthy fats out there, that's fine, but not too many of the saturated fats. So eating well is really important. We need a good amount of calcium in our diet, because we need to really be thinking about our bones from the menopause onwards. So calcium is predominantly in dairy products, but it's also in our greens as well. So if you're vegan, for example, or you're allergic to dairy, so you don't have much milk or cheese or yogurt, actually you probably need to think about whether you need to replace calcium via a supplement. And someone asked about vitamins as well, and vitamin D is the absolutely crucial one, because that's also helps to support our bones, and actually in these current times it's actually very good for our immunity as well. So vitamin D is the only kind of crucial thing that people should purchase. Exercise, really important if you can manage it. And so there are some people out there that are doing really wonderful exercise through their life. There might be, long distance runners, endurance athletes, do loads of high intensity workouts and stuff, and that's all great, but we need to give ourselves permission at this stage in life to carry on doing some cardiovascular stuff and some weight bearing stuff and some high intensity stuff, but not to stress our bodies too much. So getting up at 4 a.m. to go for a run is fine before your perimenopause, but you're going to stress your body out a bit if you do that sort of. Some people almost become addicted to exercise around this time to try as their therapy, and I can understand why that happens as well. But actually we need a balanced approach to exercise, and actually going for a walk and doing things like Pilates and yoga can become much more helpful, because they're good for us but also relaxing. And we do need to relax. Most of us are working very hard, running around trying to be everything to everybody, and actually if we don't relax and sleep and rewind and recharge, then that also isn't good, because our levels of cortisol go up in our body, which is our stress hormone, which also stops our hormones working. So there is a real reason why we say people need to take time to relax. Lots of people will march into their local health food shop or chemist or whatever, and you could spend millions of pounds on supplements. Anecdotally, they may help a few women have slightly less obvious hot sweats and flushes, for example, but there is no medical evidence that any of them are any better than taking a placebo medication. So I would never encourage someone to have a herbal menopause remedy, because I don't want to waste their money. Complementary therapies can be helpful. So someone might go and have a massage or hypnotherapy or Reiki or something like that, and there is small amounts of evidence that can be helpful, mainly because it helps people relax, but there's not a strong amount of evidence for it. There's a bit more evidence for having psychological therapy, so what we call CBT, cognitive behavioral therapy, that can help mood, and it can help sort of anxiety, and it can reduce the impact of hot sweats and flushes, but it's going to be a fairly short-term solution. So you might get 6 or 12 months benefit, and then you feel like you're back to square one again. So basically, the most effective way of dealing with the menopause is very simple. You just put back the hormones in that you've lost. So you just literally replace. You're not putting anything foreign into the body. You're just putting back in what the ovaries have run out of. And we'll talk about HRT, because I think it's really important to reassure women about HRT, because most people on the planet still think that HRT is dangerous, and it isn't. So we'll talk about HRT. I know also people ask about, well, what alternatives are there apart from what I've already just said. There are a few prescribable alternatives to hormones, but they're all a bit rubbish, if I'm being honest. So there are antidepressants, which should not be offered as the first line offering for a woman that's got perimenopausal symptoms. So if she's got low mood or anxiety and she appears to be in the perimenopause or menopause, we should not be giving antidepressants. But antidepressants can be used by people who decide not to take HRT, or for the very few people in whom HRT isn't recommended, because they can slightly reduce the impact of hot sweats and flushes, and they can improve mood. But they're not replacing your hormones, so they're not going to give you all the future health benefits that putting the hormones back in would. There is a blood pressure medication, which very old-fashioned one that can reduce hot sweats and flushes, but it's a bit rubbish and it tends to upset people's stomachs, so they can't take it anyway. And there's a few old epilepsy medications which can be slightly helpful for reducing hot sweats and flushes. So there are alternatives, but they ain't really going to cut the mustard for most people. So, which is another reason why I'm very keen that all women know. I mean, HRT is not for everybody, and everyone should have a choice about HRT, but they should be able to base that choice on the right information, not a load of myths that they've read about in the Daily Mail. So yeah, there's lots of things to do, but we always want women to know the most important thing is find out about HRT, because that is the most likely thing to get you out of this.
A lot of the employees, when asking about HRT, are saying, how do you balance the benefits with the risks? And I think it's knowing what they both are. You've already said so far, there's so many benefits. So it's just really weighing that up with the risks. I want to know more about that, really.
Absolutely. So the benefits, and that, like, if you think of, those old-fashioned weighing scales where you've got the benefits one side and the risk the other side, the benefits are phenomenally, they're going to win the heavy stakes every day for pretty much everybody. So the benefits they are proven beyond all doubt to be the most effective thing at getting rid of the symptoms. So that's obviously a big bonus. And they have been proven many times also to improve quality of life. So just, the way women function is better with their hormones around in general. We know that it has a dramatic impact on our heart health. So it can, if we start HRT within 10 years of the menopause, it reduces the risk of heart disease by a half, which is a massive number, because actually heart disease and dementia are the biggest killers of women in this country. So if you reduce the risk by a half, that's really significant. So yeah, it reduces the risk of dementia, and it hugely reduces the risk of osteoporosis as well, which, so about 1 in 3 of us will break a bone, whether that's wrist, hip, back, at some point after the menopause. And yes, okay, if you're 30 and you trip over and break your wrist, it's not that big a deal. But if you're 75 and you fall over and break your hip or your wrist, the chance of you regaining full mobility and being able to live independently is markedly reduced. So it's a big deal. And you get there's lots of other benefits, like it helps to reduce becoming obese. If you take HRT, it reduces the risk of diabetes, it reduces the risk of things like arthritis. It actually reduces our risk of getting COVID. And if we do get COVID, we're much less likely to be ill with it or die from it. So there's loads of benefits. So that's, really important for women to know. The risks. So with the right type of HRT, the risks are minimal, if present at all. So, and the risk that most people worry about, so basically, is things people worry about: am I going to have a blood clot if I take HRT? No, as long as you use the right type, and I will tell you what the right type is. Is it going to give me a heart attack or a stroke because I'm taking HRT? No, as long as you use the right stuff. And they worry about the big thing, the elephant in the room whenever you talk about HRT, is about breast cancer. Is this going to give me breast cancer? Breast cancer is really common. So if we were born after 1960, between 1 in 7 and 1 in 8 of us are going to get breast cancer at some point. That's a big number of us. There's some things we can do there's some things we can do to change that risk. There's some things we can't do at all. So we can't change the fact that we're female and we've got boobs. We can't change the fact that we're getting older, and as we get older, our risk goes up, and we can't change our relatives. So although most breast cancer, 95% of breast cancer isn't related to our genetics, there are some cases that are related to genetics. So you can't change any of that, so kind of don't worry about it. But there are things we can change, and actually lifestyle has the biggest effect on our risk of breast cancer. So actually being overweight has a massive effect on our risk of breast cancer, and drinking 2 glasses of wine every night also has a significant effect on our risk of breast cancer. So we could think about changing those things. So when we look at HRT and whether that's risky, most of the fear comes from a big study that was done 20 years ago in America called the Women's Health Initiative. And it was all a bit of a car crash of a study, but essentially one day the whole world woke up and it was on the news that you should stop HRT because it increases the risk of breast cancer. And the way that study was carried out was completely wrong. And actually the results were released to the media before anyone had checked the results. And had they actually looked properly at the results, which has been done many, many times over since then, actually the risk with HRT and breast cancer was really, really small, if at all. It was probably not statistically significant. But unfortunately, that fear has stuck. But the HRT they used in that trial was really old-fashioned stuff. It wasn't the natural hormones that we have now. So even if there was an increased risk, it's not relevant to what we do today anyway. So yes, unfortunately, many women will get breast cancer while they're on HRT, but it's not because of the HRT. It was going to happen anyway. So there are certain people that could take HRT where they don't need to worry about breast cancer or an increased breast cancer risk at all. So if you end up going on HRT before you're 50, right up until you're 50, so you might start HRT. You know, I started a lady of 27 on HRT yesterday. For the next 23 years, she's not increasing her risk of breast cancer at all. So, so that's fine. If you've had a hysterectomy, which I know someone asked a question about, you don't need the progesterone part of HRT. So you have what we call estrogen only HRT. And if you have estrogen only HRT, you actually have a lesser risk of breast cancer. So a lot of people also don't realize that. And if you need what we call the normal HRT, which we call combined, which is for people that have a womb where they have estrogen and progesterone, then there is possibly a very small risk if you look at all types of HRT overall. If you just look at what I call body identical HRT, which is the natural form of hormones that we use now as the first choice for everybody, then actually the studies have shown there isn't an increased risk for at least the first 5 years of use. And it looks like there probably isn't any increased risk beyond that. It's just that we haven't had these hormones around in big circulation for long enough to have the full sort of 10, 20 year picture, if you see what I mean. So for the vast majority, HRT is extremely safe. And the only people really that need to see a specialist really about whether it's suitable for them is people that have a cancer which is fed by estrogen. So for most people, that's breast cancer. And not all breast cancer is fed by estrogen, but some of it is. And there's also cancer in the lining of the womb, which is fed by estrogen. Everybody else, the benefits of HRT are almost certainly going to outweigh the risks. So that's people with migraines, people that are overweight, people that smoke, people that have had a blood clot before, people that have got a family history of blood clots. for example, they can all take HRT, but most of them may be told that they can't take HRT. You see what I mean? Diabetes isn't a problem. High blood pressure isn't a problem, as long as you use the right stuff. So the right stuff, as I've said, is called body identical. So all that means is it's regulated and authorized, it's available on the NHS, but it's the natural form of the hormones, and it's extracted from the yam plant. So if you look at it down a microscope, it looks exactly like what was in our ovaries before the menopause. So the estrogen part of it, we want that to go through our skin. The old-fashioned way is to have it as a tablet, and that's not wrong, but it's just not the totally safest way of doing it. If you have it through your skin in like a gel or a patch or a spray, then there's no risk of blood clot or stroke. It's really easy to use, really flexible with the dose. So you can change the dose as you go through your menopause, and the woman can be in control of the dose and up it and down it as she needs. So that's really kind of easy, simple to use. And then there's also a natural progesterone, which is a little capsule that women take at night, because it helps to protect the lining of their womb, so that we don't reactivate the lining of the womb. But it also can help us to sleep better, and it can be quite calming. So that's the two main hormones. And then the third hormone, which I don't want to forget to talk about because it is important, is testosterone. And that's sort of like the new kid on the block, in terms of, we never used to think of testosterone. So you go, well, that's for men, and it was never part of our conversation. But actually, we make loads of testosterone when we're in our 20s and 30s, and we really can miss it later on. And testosterone is really helpful for our sex drive. It helps a lot with the brain fog. Estrogen's good for brain fog, but so is testosterone. And testosterone is very good for our kind of stamina levels and our energy levels. So the difficult thing about testosterone, it's not readily available on the NHS. Well, it is for men, but it's not for women. So there are some GPs that will be quite happy to prescribe male testosterone to a woman, as long as they've adjusted the dose properly, which is crucial, because we only need 10% of what a man would need. But many GPs would say, I'm sorry, this is new, I don't understand this, this is not, it doesn't say it's for women, I can't do it, kind of thing. So that's one of our big things that we're campaigning for via the charity, and lots of other ways to get it more readily available for women. So of course anything's possible privately, but that shouldn't be the way. Women should be able to access it on the NHS, and they will be able to. Give us a few years and we'll have got it sorted.
Perfect. Before I just move on to my next question, we had an individual ask, so they've already been sort of prescribed with antidepressants. So
Yes.
Their sort of question was, can they go on to HRT whilst they're still on the antidepressants, or would they
Yes,
have to stop them?
Yeah, no, they absolutely can. So it's what we really want women to know is that if they're offered antidepressants as the first thing, and they agree to try them, and actually they don't notice any difference at all, that's not surprising, because actually what they need is the HRT. And actually antidepressants don't work well without estrogen around anyway. So they may be doing nothing because of that. But if actually she does notice a little bit of an improvement, it maybe just takes the edge off anxiety, or it just lifts her slightly, but she's still got all the other menopause symptoms, then it's absolutely fine to be on both. It's not a problem. What tends to happen is that as women feel better with HRT and they gain confidence over maybe 3, 6, 9, 12 months, she then thinks, I actually don't think I do need this antidepressant. And then she can gradually wean off it, obviously with discussion with her own GP, and often they're able to come off it. Not always, because it is possible to have genuine clinical depression and be menopausal, obviously. So some people do need both. It's just making sure someone has thought about her hormones and hasn't just gone on merrily with antidepressants and got nowhere.
Yeah, so I suppose on that then, so we hear quite a lot of people sort of not getting the support from the doctors, and you've already sort of touched on it a little bit, but if individuals don't feel like the doctors are supporting or listening or offering HRT or the right support that they feel they need, how do you best sort of suggest that they go around that and get the support that is required?
I think it's very important to not give up, basically. And it's very easy to give up when you have a door slammed in your face. And when we are menopausal or perimenopausal, we often don't have the confidence or the brain processes or the confidence to challenge or to try again. But basically, I think, you know, a lot of the education and awareness we're doing, I think, is helping the conversation. And there are more GPs out there that are going, okay, we can't avoid this menopause thing any longer. You know, it's now all over the telly and the newspapers. Rather than keep fighting it, why don't I just, you know, try and embrace it, kind of thing. So yeah, do your own research, do your own homework, go prepared, go with a list of your symptoms, or that, you know, print off some resources. So the website, the website has just changed. It was called menopausedoctor.co.uk, but it's changed name in the past 2 weeks. So it's now called www.balance-menopause.com. So the idea is it's the website which supports the Balance app, which I'll come on to. So if you go on that website, there's a medical library, and in the search box, basically, you will be able to find pretty much any resource you could possibly need. So if you suffer with migraines and you think, I bet the GP will use that as an excuse to not give me HRT, you print off the leaflet about migraines, take it, read it, and take it with you. Or if you're got high blood pressure and you think, oh, they're going to say I can't have it, print off the leaflet and take it with you. If you're you might be a bit older than the average, so let's say you're listening to this and you're 60 and your period's finished at 50, you go, oh, I'm too old now, I'm 60. Actually, nobody is too old, but the general rule of thumb before we had this most natural HRT was that if you'd gone beyond 10 years past your menopause, you shouldn't start, because it's like the horse has already bolted with disease processes, and you could make things worse. So a lot of people over the age of 60 are told, no, you're too old, forget it. But actually that is wrong. And as long as you use the right type of HRT, and you start it gradually, and you're aware that it's not as beneficial as it would have been if you started early, then it is fine. But so there's a leaflet on the website for older women, so you can go and say, I know I'm, you know, slightly past it in your eyes, but actually I'm not, thank you very much. So if you take the information and don't give up. So if someone says no, unfortunately, I know it sounds ridiculous, but you then make an appointment with one of the other GPs, or if there's only one GP in the surgery, obviously that's a bit tricky, but write a letter, you know, cool down, write a letter, put all the information in it, that I've done my research, I'd like this. And there in June of this year, some NICE guidelines came out. So NICE is the National Institute of Healthcare Excellence. They made some guidelines called shared decision making, and they're really, really helpful for healthcare professionals who maybe don't usually practice in this way, because they basically say, listen to your patient, find out what's most important to them, and talk them through the options and the pros and cons of those options. But no matter what your view is as the healthcare professional, and whether you would choose HRT or not choose HRT, doesn't mean that the patient doesn't have the right to make their own choice. So as long as you've given her some information, you know, you can go along with something that you wouldn't perhaps do yourself, if you see what I mean. So being able to set, and there was also NICE guidelines for menopause, which came out in 2015, which also really helpful. So just mentioning something like those, like, are you aware of the NICE menopause guidelines, and are you aware of the NICE shared decision making? And as long as you're polite, you know, and you're not really rude, because no GP wants to be difficult or mean or antagonistic. Literally, GPs are often told how risky HRT is by people that are focusing on old data and have not moved with the times, if you see what I mean. So don't give up, keep going, because this is the rest of your life. This is not a month that you've got this isn't a chest infection that, you know, will probably go away on its own anyway. This is the rest of your life's health. So don't give up. It's, you know, even if it turns into a bit of a project.
Yeah, that's great.
And how then, obviously you've spoken to a lot of people within your clinic, and obviously when you were a GP doing in your practice, how have people managed to deal with it within the workplace? Because obviously we're talking about it more now, which is brilliant, but obviously previously it would have been a lot more difficult for people. So how can we encourage and help and support our employees with this, really?
Well, it already sounds like you're probably leaps and bounds ahead of everybody else because we're having this conversation. So it's being aware in the same way as, you know, I expect you've got a maternity policy, because everyone's got a maternity policy. We actually need menopause policies in every workplace, because actually not every woman will need a maternity policy, but every woman will need a menopause policy. So we need to be talking about it. We need to be training up, you know, kind of line managers just to recognize that this, so if someone doesn't see themselves, their behavior is a bit different, maybe there's some performance issues, absenteeism, you know, sick leave, that sort of thing, that someone on the radar is going, could this person have an issue about menopause? And for a woman to feel that there is someone they can go to talk, that they can trust with information. There's a lot more legislation now sort of coming in about menopause and how technically it can be classed as a disability. So, you know, if you sweat all day and all night and you can't sleep, you're probably not going to be able to do your job very well, no matter what job you have. And so the important thing is to be able to have those conversations so that reasonable adjustments can be made, whether that's work hours or whether that's uniforms changing or having a fan available, or some women need an office that's nearer to a toilet because they're having issues. And all those things are really important. But what is the most important thing is there's no point giving a woman a fan and putting her near the toilet if someone doesn't say, do you know that how safe HRT is and that this could possibly solve all your problems? So unless you signpost them to help, you're only giving them so much help, if you see what I mean. So giving them like details of the website or the Balance app, for example, so you can say, do you think this might be an issue for you? It is really important, and I think many lives are saved in office chit chat about, you know, when women are fanning themselves down or whatever. Actually, I had a woman who came to see me last year who had worked in this company in a big office for donkey's years, quite a placid lady, but she clearly was struggling in her perimenopause, and she'd had a row with someone across the office and she'd flung a stapler and it had hit her colleague. So she'd been you know, sent home and disciplined, which was the reason she eventually came to help, because she realized her job was at risk. You know, and it's awful, and you just think, you know, it's you know, it's kind of vaguely funny, but it's not funny if that's you or anybody that witnessed that, really, because that is the, you know, the truth is that people struggle like that, and it affects them at home and at work. And so yeah, give women the sort of information I'm giving you now, and direct them to signposting, and just listen and understand, and, you know, support the you know, if most women go through the menopause, you know, in their 40s and 50s, that's when most people are at the peak of their career, and you want to keep these people, not let them, you know, unfortunately between 1 in 5 and 1 in 10 women will leave their job prematurely or change roles or take a demotion or not go for promotion or whatever because of the menopause, and that's ridiculous in this day and age.
Yeah, I think because it's quite a bit, not so much now, but it's been a bit taboo, people are frightened to speak up because they think that not judgment as such, but, you know, how it's looked upon that, oh, I've got a problem, and this is, you know, you're talking about things that are going on with you, and it's quite difficult to approach your line manager on that subject. So the more open we are about it, hopefully the more that will encourage others to actually turn around and say, well, hang on a minute, this is what's going on with me.
Yeah, and I think, you know, we've got so much celebrity exposure now, which is great. So, you know, if you know, maybe I wouldn't be so scared to mention to my line manager that I was struggling, because actually Davina's just told the whole, you know, world via the amazing program she did, that she's menopausal. Louise Minchin said, you know, she was struggling and couldn't read the auto cue properly. And actually, if these people that we often aspire to and look up to and think are perfect, they actually know this was really bad for me, I really struggled, but people told me to keep quiet, that we'll start talking and it will be quite normal to talk about it. And men will learn as well. Men want to know actually what's going on with their colleagues or their partner at home or their sister or their mum or daughter even. So it's a conversation for everyone actually, it's not just for the women.
Definitely. Perfect. And you've already mentioned you briefly mentioned the app and sort of questionnaires and things like that. So what is out there to help support women or support sort of friends and family of women that are going through it, to sort of point them in the right direction and help them sort of decide what the best route to go down is?
I've got my favourite books sitting here. So
we're prepared.
I have mine as well.
Yeah, brilliant. Very simple, very easy to read. Good stocking fillers. You know, just to, you know, we just want information, don't we? Even if you read it when you're 30 and you know, and you're fine for another 10 years, just, you know, just it's helpful, isn't it? This is my ultimate favourite book of all time. In my menopause vagina. It sits on my coffee table, and my children now are totally au fait with talking about genitalia, so that's fine. But that is, you know, actually probably somewhere between 70 and 90% of women at some point will struggle with their vagina or their walk to works or somewhere down there that they don't think they should talk about, whereas that just talks about it and it's really helpful. Someone asked about diet and food or something. That is the Happy Hormone Cookbook, is written by our clinic nutritionist called Emma Flint, and so that's full of lots of good recipes as well that are conducive to healthier hormones. So they're all good resources. Yeah, the Balance Menopause website and the Balance app.
I have my app. I have the app.
Yeah, I think that's what I would say is the most trusted. You know, none of those things have been funded by any pharmaceutical companies. It's all non-biased, evidence-based information, which you can trust.
Yeah, perfect. Well, I think that's all of our questions. So I just want to say a massive thank you, Sarah, because I think this would have been really useful for us as a committee. Absolutely. And then, you know, equally for all of our employees that are able to watch this or have answers to their questions, and hopefully even just listening to this might help them go in sort of the right direction to get the support that they need, or equally to prepare for what they've got to come, I suppose. But, you know, I think it's also important from, you know, myself being a younger member on the committee, to sort of know how we can support employees, or equally for, you know, line managers or the male sort of population that we've got in the workplace, to sort of understand and build their knowledge around it as well. So I think this has been really useful and will hopefully help us going forward with the rest of the things we've got to come.
Absolutely. Yeah.
It's brilliant. It's wonderful what you're doing. It's really helping us. You know, your women will thank you, and the men.